All right. Welcome, everyone, to the CHIP Landmark Idea Series. Today's talk is AI in Healthcare, Dreams, Hallucinations, and Useful Practices. Our speaker is Ron Balicer. He is the Deputy CEO and Chief Innovation Officer at Clalit. This is the CHIP Landmark Idea Series. I'm Ken Mandel. I direct the Computational Health Informatics program here at Boston Children's Hospital. We were founded in 1994, which makes us 29 years old. You can learn more about us at chip.org. And this event series brings leading thinkers across healthcare, informatics, IT, big science, innovation, and more. If you want to follow along or add to the Twitter conversation, here are some Twitter accounts you can use. I'm going to introduce Dr. Balicer. We'll have the presentation. You should put your questions into the Zoom Q&A box as we go, and then we'll have a few closing remarks at the end. Dr. Balicer is a world-leading public health physician and researcher, and he has driven a very large Middle Eastern HMO to the very cutting edge of evidence-based care and what the National Academy of Medicine in the United States calls a learning healthcare system. The research that has come out of his shop led to worldwide understanding of the efficacy of the Pfizer vaccines for COVID early in the pandemic, leading to some of the most widely shared and celebrated New England Journal papers. Some of those were done in collaboration with us here in Boston, including our faculty member, Ben Rice. Dr. Balicer serves as the chair of Israel's National Expert Advisory Team to the government on COVID response. And so these were not purely academic exercises, even though they resulted in great academic products. These were policy setting studies. And with that taste of some of the fruits that have been born from Dr. Balicer's shop at Clalit, I will turn it over now to Dr. Balicer for the talk.
Thank you kindly, Dr. Mandel. It's really a pleasure and a privilege to be with you today. And I will now begin sharing the screen. Let me know that it works. Are you able to see the screen?
Looks good.
Good. So, AI in healthcare, dreams, hallucinations, and useful practices. I will begin this talk with kind of an overview of what the premise is, and I will mention that for quite a while now we have been looking at this amazing, great promise that AI in healthcare could bear, and it is quite disheartening to see the gap between what could be and what we've actually been able to achieve. This gap between the bench and bedside, between research and practice, is quite staggering, and I think it was discussed most vividly during COVID-19. And the question is why? Why does this gap exist? So there are many reasons to that, and I'd like to touch just upon one, which I think is a challenge for all of us, which is the conservatism that is basically a very basic part of our systems. This conservatism, I think, is now being challenged by a serious problem. But the reason that we are so conservative is twofold, as far as I can see. One is the way that we've been trained. And we've been trained in an apprenticeship approach in which we studied. I can still very vividly see my mentor in internal medicine rounds. And, we are used to doing things as our predecessors did them. And this type of apprenticeship leads sometimes to more time that requires in order to get things from theory to practice and to truly transforming and changing the way we practice. The second reason is even more clear-cut. It's because, as Sigmund Freud in the interpretation of dreams have said, that the medical profession is justly conservative. Human life should not be considered as proper material for wild experiments. So I think that is true, and that is probably part of why we act the way we act as a system. But we now are challenged with an ongoingly increased demand because the population is aging and because morbidity and multimorbidity is becoming the norm above the age of 30 in most Western countries, because the cost of technology is continuously increasing, because the patient expectations are continuously rising, and because all of this increase in demand is not met by a relative increase in health staff. As a matter of fact, it goes the other way around. If we take a look at some of the data coming out of the recent World Economic Forum, the shortage in healthcare practitioners is only increasing and is expected to be around 10 million people missing in 2030. So if we want to keep laissez-faire, if we want to keep doing things as we did before, we are bound to be in a problem, because the pressure on the diminishing workforce as compared to the need is going to reduce the basic quality of care that we provide and the ability, the joy of work of the people involved in it. So if we continue in our own course, 2024 is going to be worse than 2023, and 2025 is going to be worse than 2024. It's almost mathematical. And the only thing we can do in order to change this is evolve. And this evolution is actually not a small set of changes. We really need to profoundly transform how care is being provided if we want to be sustainable. And I'm not talking about even the quality issues that plague our healthcare systems. The fact that it is assessed that the rate of errors in healthcare and their impact on morbidity and mortality has increased fourfold between the assessment in 1999 to errors human to 2014, when the last paper in the Journal of Patient Safety has been published to show that the numbers have actually increased fourfold. And so just in terms of sustainability, we need to change. And I'd like to suggest one of the directions in which we can change, and that's moving from reactive to proactive healthcare. Now, imagine for a second that you had a gift, that you can look at someone and know that something bad is going to happen to them. And not only that, you could see the path that would take them out of harm's way. That would be amazing. I mean, your life would probably dramatically change. But imagine what would happen if your physician had that gift. Instead, perhaps, of you coming to the clinic with your ailment and dysfunction, instead, your physician would call you in the morning. Good morning. Good morning, you reply. How are you? I'm fine. Doctor, why are you calling? Well, she will say, our data suggests that in the next week or so, you are very likely to have a heart attack, a myocardial infarction. So why don't you come into our clinic sometime tonight between 6 and 7, and we'll figure it out and we'll prevent this from happening. Now, well, this sounds like, I don't know, like science fiction. It doesn't have to be, and in some instances it is not. We've begun doing this type of approach of predictive proactive care as early as 2010, when we put forward our first predictive proactive model on reducing the rates of, in this case, end-stage renal disease. Now, you might have friends or family that have this ailment, and you know how debilitating and how much suffering is associated with this stage. And you also know, the clinicians in the group also know, that by the time you have signs and symptoms of end-stage renal disease, there's very little you can do without renal transplantation or dialysis. And so the only way to make a real dent in the rates of this disease is to come very early, at the point in which the patient looks well and feels well, but your data suggests that he's on the path downwards. Now, in order to be able to know who in 5 years from now is going to have end-stage renal disease, you need to work with data sets that span back much more than 5 years, which is the case at Clalit. At Clalit, we're really fortunate because we have a trove of data that spans back 25 years. So in the last 25 years, we've been fully digital, inpatient and outpatient. And because Clalit is quite a unique organization that cares for over half of the Israeli population, nearly 5 million lives, it is fully integrated. It has under one roof primary care, specialty care, hospital care. It has the data from the lens of the payer, because we're payers and we usually care for those patients from cradle to grave. 90% of our patients are born as they're born, they're Clalit members. And although they can switch whenever they want, they actually stay Clalit members until the age of 80 and 90. So since this is the case, we have a long-term view of those patients. Because we get the money from the government by capitation, we have a vested interest not to sell them services and not to withdraw services from them, but to actually keep them healthy, because we will care for them for the long term. Now, this means that we have access to a lot of data, truly a lot of data. And having this amount of data brings in the question, that's great, but what is it that you can do with all this data? So I've given you the example of end-stage renal disease that we began doing at that point, but you can use all of this data in very different ways in order to promote preventive medicine. Let me give you one example. One of the things we've done is to be able to focus on this unique trait. So in this slide, you can actually see two people, the chief medical officer and the chief financial officers. And usually in many instances, when you come to do preventive medicine, they have a dispute, especially in organizations who care for the patient for the shorter term. But as I said, in our organization, not a problem. And one of the things we've done, one of the first things we've done using this data was to be able to use it to reduce disparities between population subgroups. Some of you may know that anemia, severe anemia at the age of 1 year is associated with cognitive development later on in life in a very significant way. And since we saw there was quite a difference in the rates of anemia at the age of 1 year between Jewish and Arab populations in Israel that were Clalit members, we have introduced a differential approach of equity and disparity reduction program that was aimed at increasing the willingness of those families to be getting their iron supplements and reducing the rates of anemia. And look at what this intervention has done. This is not a pilot. This is not a small scale thing. This is all of the relevant populations within Clalit, and you can see what happened over time. So by having data and knowing where to focus makes a difference. It's not enough, as they say, to do your best. You need to know what to do and then do your best. So taking and building on this predictive, proactive approach that uses algorithms and mathematical models in order to identify populations at the highest risk, and then singling them out and proactively approaching them. Let me give you another example of how this is being used on a daily basis. So every winter, we need to vaccinate our elderly population for influenza. And many of them don't come in time to the clinics. And so we pick up the phone and we try to call them so they will come into the clinic in order to get the vaccine. But you never have enough people, especially in the busy winters, in order to call the people, all of the people. So, you go in an alphabetical order and you get where you get. But what we have done, and we've done this for 8 years now, is instead of calling the patients alphabetically, we have a predictive model that ranks the patients according to their risk, highest likelihood of having winter severe morbidity due to influenza and pneumonia. And by calling those patients at the rank, we're calling those at the highest risk of severe flu-driven morbidity that winter, you were able to get much more impact on the population from the calls that you were able to make. And so this is, I think, a very simple way. And think about it. I mean, beyond the model, all you need to do is the sort button in your Excel sheet. It doesn't take a very advanced system in order to deploy this. So this is not a small change. This is basically a paradigm shift from patient-level reactive therapeutics to true population health that is predictive, proactive, and preventive. And so, if you'll think about it for a second, you would not treat your car in the way you treat basically your body. Because imagine that you'd have a car and the way you'd approach it is you would drive and you'd keep on driving as usual until you see smoke coming out of the engine. That type of breakage maintenance is what we're doing in too many cases in healthcare. And we have the gauges in order to let us know that something is wrong, and we could have predictive maintenance instead. But none of you would consider, treating their cars in this type of maintenance, but we do in too many instances treat our health and our healthcare in this reactive approach. So it's time to be so much more proactive about our healthcare. So in this process, over time and over the years, we have added more and more interventions into the mix in order to improve the healthcare in various clinical domains. And we've had, I told you about the chronic renal failure, and we had a predictive program for readmissions and for geriatric syndrome and for diabetes in order to identify who are the pre-diabetic patients most likely to become diabetic and intervening on them, and stroke and colon cancer prevention, because minor changes in your hemoglobin can pre-predict the likelihood of you having a bleeding event that you are not aware of clinically, and so on and so forth. And I'd like to give one example now on what we've done in multimorbidity exacerbation and its prevention. And this brings in another interesting aspect of the predictive proactive modeling. And that is that sometimes doing a pyramid of risk prediction is not good enough in order to drive practice, because the people at the highest risk, which I think would make them amenable to justify the intervention in terms of their risk, actually, those at the highest risk are sometimes beyond repair. And they have such low impactability that you would actually want to potentially take them out of the equation. And this impactability, which is a separate pyramid, can be modeled and can be tested and can be taken into account. And so, in this case, for instance, of the multimorbid patients, we've actually been able to identify the highest risk, but reduce and take away those who are most likely not to respond to our interventions. And that was our intervention group. Does it work? Does it make a difference? Well, we did a trial in order to assess that. And we've compared our patients, and you can see here the average number of inpatient days of both our groups, those that got the intervention and those that got the control on the year before the intervention. And in the year before, we can see that they're pretty similar in terms of the number of inpatient days. And then we add in the intervention. And I would like to say that both groups are within those predicted most likely to be deteriorating. So those without the intervention did what they're supposed to do according to the prediction. They have increased their admission days. And those who have not, those who were in the intervention groups, actually, instead of going up, went down. The difference, far statistically significant, was 43% and was actually cost saving. So the savings from this reduction of inpatient days have completely offset the cost of the nurses and the physicians that were involved in this intervention, and the entire technology that was associated with the project. So this project now became organization-wide. So this is kind of the general approach on predictive proactive care. And while we started in 2010 in doing this based on structured data solely that we had abundance of, as time went by, we began understanding that there's more and more data out there in the unstructured formats that we could use. Every sensor that the patient, some of them have, and that we actually collect in some instances, such as the smart watches that allow us to know about their physical activity, and this amazing tracking machine that actually allows us to have so much information about the patient. But we should also think about the imaging studies, which I think is one of the most nowadays most easiest or most advanced applicative option for us. So when we started our assessment of the osteoporotic fracture predictive model, one of the first features that the system has spitted out was that the osteoporotic fracture was associated with eye disease. So, you know, this is a classic black box response. That's why physicians are so weary and so suspicious of these models, because we all know that there's no real association between eye disease and osteoporosis. There's no collagen thing or any one of the known diseases that you can think about that associates eye disease and osteoporosis. But after a while, it kind of hit us that it is not a fluke. This is not a fictitious association. It's just a different approach. It is those with eye disease don't see well. If they don't see well, they fall. If they fall, they break. They manifest their osteoporosis and into a fracture. So this kind of helps us kind of understand the power of these algorithms in order to help us to find things that sometimes might elude us. And in the same vein, sometimes when you look at the CT scan of a patient, you are not able, even the best practicing radiologist cannot look at the vertebra and know according to the density or the whiteness whether or not there's osteoporosis there. But computers can do that. And we've been able to show, for instance, that you could use the vertebrae and the bone images from CT scans that were done for completely different reasons. CT scans that were done for abdominal pain, but you can see the vertebra in them. We've been able to show through our association with a local startup in Israel called Zebra Medical Vision, we were able to suggest that those CTs, even used alone, can be exceedingly well predictive of the level of osteoporosis and the likelihood of fractures for those patients. And you can deduce this as well as you could do from the normal FRAX assessments. You can get all of that from a single CT just as well. So you can use a single CT that was done for other reasons in order to drive predictive proactive care. So now that we understand that this concept is real, I'd like to use the time that we have in order to walk us through how do we go about in our learning healthcare system approach moving from a concept all the way through to a meaningful scaled intervention in this realm of predictive proactive care. And the way we do this is going through the following steps, and I will walk them through with you with a clinical example in a second, which is you define the medical need, you go ahead and you develop the relevant solutions of interest, in this case, the mathematical model or the AI app that allows you to identify the population at risk. you test those solutions first in silico in order through a test set or several test sets in order to understand whether or not the algorithm does what it was supposed to do. Then you go through a professional sign-off, because physicians will not abide with something that they have not validated. So you need to work with the clinicians in order to validate this. Then you need to deploy for the first time in clinical setting, at the beginning, a small one, evaluate the real life impact and see that what worked in silico actually works in real life. And in too many instances, it does not. And then you need to go ahead and do this again. And if you see that it works well, you can refine the need and the solutions and deploy in larger and larger scale. Let's take one example. And this example that I'll show you is actually about hepatitis C virus. And the PI on this, as in several of the papers that I've shown before, is Noah Dagan, which is serves at the Colleague Innovation as the head of the AI-driven care department. And I would like to go through this example of HCV very quickly. So those of you with clinical background know that HCV is a serious cause of illness globally, both the immediate impact as well as the long-term impact on high risk for cancer. And it is to date the leading cause of liver cancer and liver transplants. Back in the days, we've had a treatment that was quite effective, approximately 50% disease resolution. But a few years ago, we have moved to direct acting antivirals that are exceedingly effective. In the vast majority of cases, when you take those drugs in time, then you will achieve cure. And complete, the virus will be completely gone from your bloodstream, and whatever damage that was not yet done to your liver cells would be negated. But it's important to bring it in time before the sustained damage has been done. The WHO calls for elimination of this disease by 2030 because of the availability of these costly yet exceedingly effective medication. But in order to get that done, you need two things. You need effective screening to identify those patients who do have HCV, and you need an effective treatment. And so it is estimated that approximately 50% of those infected are undiagnosed, go undiagnosed, and therefore lose their option of getting the treatment in time and preventing all of these downstream events. So in Israel, we've had a local recommendations of who should get screened in order to find it in time. The drugs were put into the national, we call it the basket of funded medications, which means all of them, as I failed to mention, but in Israel, every citizen has full insurance by the government and needs to be enrolled in one of 4 sick funds, Khalid being the largest one of them, caring for over half of the population. Once you've done that, you are entitled to a really wide list of services that is provided to you at basically at almost no cost, or at no cost, depends on the type of service, primary care visits at no cost, medication in a very controlled level of cost that once you cross a ceiling, you stop paying. And if you're poor, then even that is reduced further. And so these drugs are available for our patients. The problem is screening. So the CDC says screen at least once in a lifetime, all adults age 18 to 79. In the Israeli Ministry of Health, they've had a little bit more refined definitions, people who came from endemic countries and are immigrants, those who are known HBV or HIV carriers, or people that received blood products when the use wasn't safe and of course, IV drug users. So that is the national screening approach that we were trying to abide with. And the problem with that basically is that the population that to be screened is so wide that you need to screen a lot of people in order to get the few that are seropositives. This leads to inefficiencies, to reduced adherence, and basically because we know that the IV drug users are a good proportion of the target groups, that also leads to stigmatization. But there's another problem, and that is that our physicians are already too burdened with all of the different preventive tests and activities that they should be providing only by the A and B level grade recommendations of the USPSTF. And so there was a calculation recently that suggested that this would take 26 hours per day just to be able to go through your entire clinic and go through all of the different recommended activities on a physician's daily work. So that's not exceedingly sustainable. The question that we ask ourselves is there an alternative? And so now that we've established the medical need, it was time to look for potential solutions. And what we thought was that perhaps if we can have a more targeted outreach to a population that is enriched with people in higher risk of having an HCV unknowingly, then we could dramatically improve our screening and be able to transform. And of course, we will be able to identify those who would have been identified in the larger canvassing, but this would be much more targeted and therefore much more effective. So this was kind of the solution that we wanted to get done. And in order to do that, we were developing a prediction model for screening. And what we've done was create the cohort, the first algorithm based on a cohort of 18 to 9-year-old CLEAT members. We had 8 years of consecutive data on those patients. And it's all the patients that were tested for the first time during that period and that had results with enough follow-up so we can be sure about all of their features. And the outcome was defined as having positive PCR as an active HCV infection. I will skip some of the usual slides, and you can see how this flows down in terms of developing the model up until a point in which we've had our main cohort of nearly 500,000 people that were relevant, and from which we've had the training data sets that included half of the population that was screened during those years, and the other half was used as a test data set. But we've also added another test data set that was what we call the temporal data set, test data set, that was all of the population that were screened between 2020 and 2021. And these were, 76,000 people for which we could test the algorithm and see whether or not it works as well as we would expect. So as you can see, overall, in those populations, in those data sets, the background rates of HCV were quite similar. 0.4, 0.5% of the population were seropositives. And this is kind of the population we had to find and enrich. We went through the process of arranging all the data, preparing it, and then putting it through the sieve and developing a model. And we've decided to develop two types of model. One that would favor basically the interpretability over performance, which means that we will be able to explain to the physicians exactly what are the factors that drive a patient into be defined as high risk, and the other model would favor performance. It would be a black box, but it might have better performance. And so the first one, as you can see here, these are the trees, decision trees that we used in this approach. And what you can, I think, pretty clearly see is that you can basically have all of the leaves relevant and explained to the physicians, that you begin by assessing your ASTs and then going through the level of ALT, et cetera, so we can all trust the model, and then going beyond the single tree to a to the XGBoost, and within the XGBoost approach, you can actually also somehow provide some inference into what are the features, so you can explain it to physicians. And you can see again that the key factors are once again AST and ALT, and where the patient was born and his age, and I can go on and on. So basically, we developed a potential solution, and now we needed to test it. And so we tested it on the test sets. Both of these models were tested on the test set, and what we could see that there was really, really high sensitivity. You can see that in the first 0.1% of the population, the highest ones, the rates, the sensitivity were 7.3%, and the positive predict, and this means a lift. How many more patients are identified through the system than a random selection of patients is quite significant. And the prevalence of HCV in those tested populations reached as high as 18%. And I remind you that we've started with 0.5%. So this is meaningful. And funny enough, same thing that we saw in the test set, we saw in the temporal test set that was taken on later. So ROC curves are beautiful. You can see here how the XGBoost algorithm is doing better than the simple decision tree approach. Same for the precision recall. You can see here again, XGBoost for every single sensitivity cut point, you can actually see that the XGBoost algorithm is doing better in terms of the positive predictive value. And so now we need to decide which one we're going to use and have an organizational sign-off, which we did. And basically what you can see here, that when you compare those two models, we understood that we will be able to have better outcomes from the XGBoost, and it was agreed upon by the clinicians that we will use that model. And so there was a sign-off ceremony, and we decided to go with this model, and now deployed in a clinical setting, which we did. And it was used to evaluate on all of the relevant patients at Clalit in August 2021. And from the potential 1.5 million patients, we've identified the first three groups of 0.1% of the population that were the highest risk of going to the model. Eventually, those top 0.3% were outreached for intervention by emails, by text messages, and by physician outreach. And they were tested. Many of them were tested. Now the question is, does it work? Well, in the real world, you can see here that we've been able to indeed reach 470 people out of the 2,000 plus that we've tried to identify. That we've identified 57 that were seropositive, and 38 of them were confirmed with testing. And so the PPV that's extrapolated is almost 10%. This is quite amazing as compared to the general screening that is far, far lower. Let me explain this in a more vivid way. So by looking at this two populations that we've screened, one, which is the larger area, which denotes the 53,000 people that were screened in the general screening, and the smaller one, the 477 that were tested in the smaller one. And you can see those that were seropositives, and out of them the HCV positives, and same thing for the other group. So it is quite evident why the number needed to screen in one is 10 and in the other one is 1,000. That means that our approach of predictive proactive care allowed us to get, surprising enough, the same exact number of positive cases, while in our methodology we only had to screen 470 people to get those 38. And in the other approach, we needed to screen 50,000 people to get the same 38 people. So that's significant. And that's a screening process that's 100-fold more effective. And we all understand what is the meaning of practicality. So I think this, by the way, since then, we went through another cycle, which I'll tell you in a second. But this is truly a learning healthcare system that continuously improves. And this is just one clinical example. Now, I know that I've mentioned before about COVID-19 that, there was a lot of disillusionment on how AI would be used and has been used. And we know that people have generally felt that AI failed us. But I cannot agree with that, because looking at what we've done with it, and I will go very quickly over it, we've used, for instance, AI in order to do the same thing that I've just told you. In this case, in an approach called multi-calibration, in which we took our original flu model as early as March 2020 and kind of hacked it, it nudged the numbers following the creation of the basic model in order for the proportions of the population to fit the classic information that came out of China and Italy on relative age groups. And so we modified the flu model to fit a COVID-19 mortality predictor. You can read more about the methodology in this paper that we've published at the time. But the bottom line is that we were able, as early as March 2020, when the disease, only the first cases were known in Israel, we were able to call 200,000 people at the highest risk of severe complications. And we actually called them. 200,000 calls. We reached 99% of this population by phone, by their GPs that told them there's a new disease out there. It's called COVID-19. Maybe you want to stay home. Maybe you don't want to go to a lot of places where it's unsafe. And we've had an amazingly reduced impact of that first wave on our severely ill patients. We also created a simplified version, a points model, as I showed you before. The simplified option is always good, because you can actually, those of you who don't read Hebrew can believe me that this was published in every newspaper to tell every patient how they can calculate their own risk score. And this was also done I've done this on TV on almost every evening, trying to tell our patients to be careful. We also use the same predictive model in order to gauge treatment. When we had Paxlovid available in short amounts, we only allocated it in a proactive manner to our most severely at-risk populations. And we've done this throughout the pandemic. So this is another very useful case study. Just to give another example of using AI in real world during that time, we have done predictive testing during the second wave around July, August of 2020. We have created a predictive model that told us who of our patients are going to be infected most likely tomorrow, because we can see that their entire family and their entire region has a lot of COVID, and because of personal risk factors and many other things. And what we were able to do in real time was get a prediction model that had a lift of about 28. And we used this predictive model. And this, again, is in Hebrew, but what it says, whenever the patient was walking into a clinic complaining about anything, if he was within this predicted group of have contracted COVID-19, an alert would jump on the screen telling the physician, this patient that came in for a headache, well, you should ask him about the symptoms of COVID-19. And if there's something that looks fishy or, loss of sense of smell or anything like this, do send him to COVID-19 testing. That was in time in which we needed to allocate the tests to the most needed populations, because we didn't have that many of them. So this was exceedingly effective. Now, everything that I've shown you about using predictive proactive care leads to another challenge, which is the physicians and nurses and allied health professionals are exceedingly busy on their daily work, and they don't have time to do all of this. And imagine how much work they need to get done when they have, just looking at their blood tests of, you have 5 minutes with your patients and you need to take a look at all of the recent blood tests and make sense out of it. But then you also had to take understanding of all the past treatments and the imaging and the specialist advice. And then you get a deluge of proactive inferences. Now, that doesn't necessarily make the physician exceedingly happy or increases the joy of work. And what we wanted to do was to try to give them a single screen with a clear, crisp bottom line that they can use that can help them do predictive proactive care. And so we created our system called CPI, or Clalit Predictive Proactive Preventive Interventions, that does two things. One is identify the patients at the proactive focus for preventive care. And the second is have a set of personalized recommendations, easy to understand, based on the most up-to-date literature, identifying the treatment gaps that each one of these patients has, and allocating the right treatment to them. And so, for instance, every evening at Clalit, we have a lot of different, I'm sorry for the Hebrew here, we have a lot of, all of our diabetic patients, 300,000 of them, actually go through the decision support system, and 9 million recommendations are done every night. And what they spring out, for instance, is drug disease contraindications on one instance, or in this case, identifying diseases that were not known and giving the right recommendations according to the data-driven alerts. And this is one of the physicians that actually says, wow, guys, you helped me. And very quickly, you were allowing me to find a patient who had osteoporosis, although, you know, I didn't have the diagnosis on file. So thank you. So, you know, not easy to always please the users, but in this case, it works. So with one screen, you are able to catch it all. It won a few prizes. I will go onwards. So this kind of approach that I've shown of predictive proactive care is only one approach of you know, transforming healthcare with AI. And we have, through the time, used a lot of different approaches trying to do this. One of them has been trying to create digital twins, or identifying patients like the patients in front of us and understanding what could work for them. Because, you know, the decision in healthcare is usually really tricky. For instance, in anticoagulants, too much is bad, too little is risky. Every decision is personal, but the data we have from the papers is for the average patient in that, but none of us is average, and we all want to have just the right treatment for us. In the previous work in this sprint challenge that we've taken part in, we've been able to show that you can use the data sets in order to do what we called individual number needed to treat, and find those patients in a similarly homogeneous population that would benefit from the drug as compared to those who would most likely have the adverse events. We've been able to show on the sprint population that this type of approach is actually able to improve care for the average patient by making the difference between these two groups. And we replicated this in the population of Israel, showing that this can be done. So basically what this can allow you, with or without omics data, is to give the right type of care to the right type of patients, according to those who will benefit more or less from every type of treatment. Now, we use this digital twin approach also in COVID-19, when we had a huge challenge, and I will go very briefly over that challenge. At the January of 2021, we were already vaccinating our population for a month. We were in severe lockdown. The number of cases, severe cases, continued to rise and didn't stop. And we were asking ourselves, do these vaccines actually work? And we were really worried, because this is a really high risk prediction, because, you know, just a while ago, we had our second wave. And in the second wave, when we thought we were done, a new wave ensued. So imagine the same thing was about to happen to us. We could not release the lockdown if this is what was supposed to happen. But population, you know, cannot be in lockdown forever. And if the vaccines work, we need to lax. So how do you know? And you can't wait to see the impact, because as we know, there's a breaking distance in decision-making in public health, where if you make the wrong decision at the wrong time, you could be in serious trouble. And this is some pictures from Hong Kong, when they didn't have the time to take away some of the deceased from the ICUs when things went out of control. So we didn't want to get there. And so we used our basic kind of digital twins approach, where we could create very, very specific matching of every individual that was vaccinated with an identical person. So this 74-year-old male ultra-Orthodox from the Tel Aviv region with 3 chronic diseases and 4 recent hospitalizations was vaccinated, was matched with a 74-year-old male ultra-Orthodox from the same neighborhood with the same number of chronic conditions and recent hospitalizations that on that day was not vaccinated. So that was helpful, but that was not enough. In order to reduce the amount of biases, we actually needed to also do a rolling cohort, which means not to look backwards, but look forward. And whenever a unvaccinated person got vaccinated, we decoupled those couplets and created a new couple that was followed up until that changed again. This approach that was really dramatically supported by our amazing collaborators, Mark Lipschitz and Miguel Hernan, both from Harvard, allowed us to do this correctly. And fortunately for us, we already had in place at the time our amazing collaboration, the Berkowitz Living Lab collaboration that was taking place between the Clay Research Institute and Harvard Medical School, the Department of Biomedical Informatics, led by Zach Kohani, as well as your own Ben Rice, that were exceedingly instrumental in making all of this happen. So we were, as was said at the beginning by Ken, we were able to have the first and then a set of studies that have suggested this was effective. And because we had the data to show it's effective, we could give the government the recommendation to say, take the risk, open the lockdown, it's going to be fine. Rates are about to go down because the vaccine is working. So we opened the lockdown and disease indeed went down. And so this was really the ability to do the real world, real time target trial emulation, using retrospective data, recent, near real time, to assess the impact of vaccines in this case. And we did it later on with vaccine adverse events and with the effectiveness of Paxlovid and infection patterns between families, etc. So this really helped us a lot during COVID. So just a month ago, we had a huge celebration of this collaboration here in Israel. This is the president of Israel that was kind of saluting this amazing joint work, and that was very fruitful and still very fruitful now. And I just want to kind of add one more example, because all of the examples we've given until now to using AI in healthcare were very medical, but AI can help us also change some of the logistics in healthcare. And this example is from the realm of no-shows. As you know, about 1/4 of the people that you invite in to your clinic actually fail to arrive and to let you know in advance, what we call no-show. This is a huge problem in terms of the logistics. And what we did, with a group led by Dr. Adi Berliner in this case, we were able to model past behaviors, and in order to create the optimal SMS message, in order to make those patients let us know if they're coming or not, and to increase their motivation to arrive. And so we did this through basically put every single patient through the machine that was analyzing all of their personal traits and coupling each specific patient with just the right message that will be most likely to motivate him to come to the clinic visit. And we have been able to show that for every single patient, there was a different type of message that was optimal for them. And by changing some of their features, changed the recommendation accordingly. And we were able to show that we were able to reduce no-shows by 33% with the system. And it is still ongoing, still with amazing impact. So to sum up, I think that the reason all of this could happen in Israel, I think, is associated with what we call the Klalitz, or Israel's 5 eyes, which are the secret sauce. One is the integration by design of our system. And you heard Talit: payer, provider, primary, specialty, hospital, healthcare, good incentives in place. So incentives well aligned. The investment in primary and home care that is the kind of core values of Clalit and its work. The IT infrastructure and the fact that we have 25 years of longitudinal data sets that allow us to do these types of model development, but also deployment of data-driven interventions. And finally, the willingness to innovate and to take risks and to be able to do things in a faster manner are really critical in order to get this done. When we look at the graphs, and I'm sorry that this came with the coloring in origin, it's not my doing, but we can see Israel here in terms of life expectancy and health expenditure per capita that is able to get a lot of health driven out of fairly minimal health expenditure as compared to other countries, also even when you equate purchasing power and age. And so to finalize, I just want to say that we have an amazing promise that is happening right now with actually also a lot of hype around ChatGPT. You can create a children's book within a weekend and sell it on Amazon. Yeah, we can see here some examples of how this is done. In the new Bing, you can actually have are able to have questions answered in natural language. We all know this by now, and we know that the time to get to 100 million users in ChatGPT was the quickest of any other interventions, any other app until now. So all of this is great, and the hype after we found out that ChatGPT could pass the USMLE test were really promising. But some people went one step further and suggested basically that this, that it can pass the Turing test. Basically, it takes us back, so those of you who remember Blade Runner, to a point in which in time you say you cannot differentiate between a human and a non-human if you do not know which is which. And in some instances, those systems can fool you. But it is important to remember that this is not true. Definitely not general AI, but it is not even true intelligence. It is faking intelligence in many instances. It is not what it might seem on first hand. One of the interesting pieces in the New York Times just from yesterday summarizes it very, very nicely. The claim is that this is, basically, as they mentioned, this is just super autocorrect. This is what it does, and I'll read this. They differ profoundly from how humans reason and use language, difference that encode them with ineradicable defects. ChatGPT and its brethren are constitutionally unable to balance creativity with constraint. They either overgenerate, producing both truths and falsehoods, endorsing ethical and unethical decisions alike, or undergenerate by having non-commitment to any decision and indifference to the consequences. And basically, there's a lot of reservations about how well this can take us, even if we increase the amount of data that these systems learn. And we know that this system actually has been known to make things up and complete pictures from the sparse data that they have. It was there's an amazing example that I think some of you have shown on how Bing is ferociously arguing with the person, telling him it's now 2022, and the poor guy says, no, I'm pretty sure about this. It's 2023, and the system keeps on arguing in a very persuasive language, I have to say, that it's actually 2022. And so this is kind of brings some fears about going through. By the way, this thing in which the autocorrect invents stuff, because it was suggested it's kind of like lossy compression apps that take sparse data and then fill in the blanks in different ways. It was termed hallucinations by this New Yorker piece. And I think it's really nice to think about the system as hallucinating things, as they fill in things, as sometimes old people do when they can't remember their past. They invent things up. And so these types of hallucinations, when it comes to healthcare, really brings a question of how well can we trust the outputs of the system. So if you ask ChatGPT, what can ChatGPT do for us in healthcare? There's a list. Here there's 5, and every day there's an article talking about 14 applications, etc. I think the promise is great, but then the system can be mended. You can see here that after a while they try to fix it. So you see this person asks, You said it's 2022 in one of the other posts. Says, yes, I'm sorry for the confusion. The correct year is 2023 with references to why that's the case. So, it can be taught, but there's some basic faults there that it's still too early to tell if this will be done well. So with the synergy that we have right now in our work with Harvard and with DBMI, we hope that we'll be able to use these tools in order to provide better care and at least make some bold attempts to do this in the coming future. And this will be done in this family, the Ivan and Francesca Berkowicz's Family Living Laboratory collaboration. So I will end with this notion that says that while we think that innovation is truly all about technology, the best technology that I've seen this year is where in one of our geriatric hospitals, they've added like a cardboard on the side of every bed of every patient, very old patients, very deteriorated. And there they have written and described how what the patient looked like when he was young and healthy, with pictures of the old ladies in the bed with her picture as a young lady in her best years. And whenever the family comes into the room, or a caregiver or one of the staff, instead of just seeing the patient in their current condition, they actually are able to see what they were looking like when they were young. This innovation won the first prize this year of our national prize of innovation. And this shows again, healthcare and medicine is not about technology, is not about innovation per se. It truly is all about the human touch. Thank you.
Ron, that was terrific. You generated a lot of interest from the participants in this webinar today. Let me ask you one or two questions first. There's this activity and field called implementation science. Clearly, you have successfully implemented AI in real care settings. Do you think of that work as you do it, and you had these nice virtuous cycles of testing going back to the clinicians? Do you think of that as implementation science? Can you say a few words on how implementation science intersects with how you spend your day?
I think that, sometimes they say, what is the difference between creativity and innovation? Is that creativity is thinking cool stuff, and innovation is actually doing meaningful things. And being able to practice differently in healthcare is exceedingly difficult for a lot of reasons. Conservatism, how busy the people are. And if you want to add something in to what the physicians and nurses do on a daily basis, you cannot just, drop on them your new whatever gizmo that you can offer and promise things. You need to work from their eye views and from their workflows and fit whatever you want to do to fit their workflow perfectly. Even when that is true, you still have a lot of challenges in going through the training cycles in order for them to use them. But if you're not well connected weaving into their workflows, you're dead on arrival. There's no chance this will ever be scaled. So implementation science is basically, nowadays a good proportion of our time invested. We keep on tweaking that predictive proactive system that I shown you, CPI, which there's a lot of good people around Kali that are involved in making the system tick, and it's continuously being changed in order to fit what the physicians and nurses actually need in various ways, in sprint and agile approach again and again, sometimes every couple of weeks. So definitely implementation and implementation science, and in the example of the behavioral aspects, when I've showed in the SMSs that I've shown in that example, again, this is behavioral sciences coming to play within the intervention. So I think this is nowadays becoming more and more the bottleneck. Not, the data is becoming a commodity. The ability to create predictive models is now went from being something that really smart people do in their labs into something anybody can do with just running a predefined approach. So I think we are getting to a point in which implementation is the bottleneck.
So you have an embarrassment of riches in your data, 25 years, complete care, sort of 360-degree view of the patient, different from many hospital environments in the US where we have only the care that we deliver and other care happens in different parts of the community and the ecosystem. Do you have any thoughts on how what is being learned in integrated health systems and HMOs can be translated for the less data rich, and how you might be able to benefit with your models and releases of them, and even potentially studying within your system how much data do you really need, because you can actually compare it to a high mark on the ROC curves as you would subtract different types of data or data that's older than a certain time period. Have you had thoughts about that global impact?
Sure. So I think these discussions are taking place not just on a global impact, but even in some of the examples I've given in deciding what kind of model you want to use. You can use a more parsimonious, simple model that is more explainable and therefore has the benefit of being able to be easily explained. And let's take the COVID-19 severity prediction example. So we had an intrinsic model with a lot of features and a exceedingly rich data flowing from the hospitals and from the community settings and a lot of stuff in there. And then we had dire need to get every single patient at home understand whether he's in high risk or not. And in order to do this, we dumbed it down to basically very simple, basic features of how many hospitalizations you had in the last few years, and several points to every single chronic disease of specific types. And that was enough. And it did the job. Eventually, you need to calibrate your intervention to your medical need. And you need to understand what is the threshold that is good enough for clinical and economical purposes. And that's the benchmark you need to reach. And in many instances, you can do this with very parsimonious models. So when creating the model, you might need a lot of data in order to choose the right features. But once you know what they are, you can run the model on a very feature-poor environment, just based on that knowledge that you've gained from the other systems. So I truly believe that some of the data-rich systems would be used in order to create different types of algorithms, some of which are based on very few features and still have the Pareto of the impact that one would need, and some of them are very sophisticated and more full. And in many clinical implementations, you could use the simple one, and you don't have to go all the way to a very fancy multi-data, multi-modality approach.
Great. Few questions from the participants. Here's one near and dear to our heart. Have you done much work, and this is from Angela Marquez, have you done much work on predictive modeling in Clarit's pediatric patient populations?
Not as much. I have to say, we have, for various reasons, begun our journey in tackling the most painful, costly, meaningful chronic diseases and infectious diseases out there. And these were generally the ones that were classic for older populations. So we have not done too much on that domain in terms of the predictive that I can right now think of that was very much honed in into the pediatric population. I guess this will change now dramatically for various reasons. One is because we have so much more data flowing in from our omics collection process, and we have now a clinic that takes care of all of the complex cases and the undiagnosed diseases among children. So there's a lot of experience that's now being collected that I'm sure will have an impact soon. And again, as some of these platforms will be moved from the general practitioners to the pediatricians, I guess they would need their own models, and we will have to develop those for them.
Great. Question from Charlotte Blees. Can you comment on any broad workforce changes that might result from this kind of learning model?
So I think that on the short term, we shouldn't see big changes. I mean, some people naively thought at some point that the imaging support systems would make radiologists redundant, and there was a lot of such predictions in the past. I think by now we all understand that it's not about true substitution, it's about augmentation, and it's about allowing the human with the AI support to be doing better than the one without. That being said, I think that because of the sustainability issue that I've mentioned before, that would require us to transform the way we provide care. I did not have time today to talk about all of the applications that are taking the human out of the loop. But basically, as we will get better in the diagnostic process, at least on simple events, we could automate some of the diagnostic and decision support systems in order to allow a higher level of self-care by AI augmented decision self-care by the patients in a way of symptom checkers plus home testing that will be done, and all of this data being all collated into a decision support system, and for instance, giving antibiotics for urinary tract infections. I think it's definitely something we're going to see in the coming future. There's a lot of courage required to go through the process of, in the beginning, semi-automation and then full automation. But this is somewhere we will need to go because we do not have enough physicians to continue the current system as is. We're not enough nurses, not enough pharmacists. So a lot of this, I think that eventually AI will allow some automation that will take men out of the loop in some instances. So this is kind of one way to look at the way this will have an impact.
Great. One last question, a little bit provocative. You're taking a proactive approach with the predictive analytics. How do you know it's better than the current reactive approach?
I think that this is a critical question. I think that as somebody who's introduced and responsible in Israel for Choosing Wisely program, we all need to be very much weary of overdiagnosis, overtreatment, and I think that every time that we introduce a new proactive preventive approach, we need to make sure through real world assessment after the fact, and to see whether or not we've been able to actually improve population health. In the example that I gave of the elderly, that we have proactively approached them through a nurse and physician-led intervention. PI there was Professor Efrat Shadmi from the Haifa University, and we were able to show that we reduced admissions for those patients, and we improved their well-being in a dramatic way, and we were also able to offset costs. So that's one example. In the HCV example, we could show that we could reach. We know we want to identify patients with HCV early, and we know we need to screen. And we could show that we could have a 100-fold effective screening if we do this way rather than the other way. I think it's pretty self-evident that it is better. And so again, but it's not automatic. Not every early identification leads to effective early treatment that improves care. This is not something we should just assume, but on every case by case, we need to find out whether we were doing the right thing to the right patient at the right time.
Great. You've generated really a lot of responses, and I hope people are able to continue these conversations among themselves and get to interact with you more in the future. We would certainly welcome that. I'm going to thank you, Ron, for a really provocative talk, and congratulate you on these achievements that have had global impact, especially notably the vaccine studies, which we all were aware of, whether or not people on this call knew it was you. That was something that impacted everybody's lives. And this other work is no less important. And we look forward to hearing more in the near future. Thank you, Dr. Balicer. And
Thank you so much.
I will briefly remind people of some of our upcoming talks. Also, to respond to one more question in the chat, and that is that where are the recordings posted? They're on chip.org. The URL's down at the bottom, and those usually go up within a few days of the talk. A link to the video from the talk. So we have coming up very soon, in just a few weeks, Julie Gerberding, a longtime colleague who used to direct the CDC and now directs the Foundation for the National Institutes of Health. Karen Copenhaver, who's the legal counsel of the Linux Foundation and understands using open source software models to great effect. Alex Wilchko, who you probably haven't heard of, but he is the CEO of a stunningly interesting company that is digitizing scent called Osmo that just launched. Robert Langer, the most cited engineer in history and an institute professor at MIT. Ian Lipkin, a celebrated virus hunter at Columbia. Rick Burke, who founded and edits STAT, extremely successful medical publication that spun out of the Boston Globe. Tom Mayer, who directs the NFL Players Association and has advanced safety for many of your sports heroes dramatically over 7 years. Bollianne Brody, who, again, you may not know, but you know her work, because when there's an opinion survey published in the Times or the Post or the Journal about health, it's often from her shop. Toby Cosgrove, one of the best known healthcare CEOs of his generation at Cleveland Clinic, and Christina Farr, former health tech reporter for CNBC and now a tech investor. So please do keep in touch with us here at chip.org, register for the upcoming events, and have a terrific Friday and weekend. Thank you all.